So today what I'm going to talk about is medical terminology, and this is not going to be a comprehensive presentation on medical terminology. This is just going to be what we can do to get ready for chest x-ray and abdomen x-rays. So it's going to be very limited in scope, and the remainder of the medical terminology that we'll talk about in the recordings and in class, we'll pick up with the individual sections. So it's going to be pretty limited. So the credits for this go to Merrill's Atlas of Radiographic Positioning. Some of the slides in the presentation come from there, and some of the slides come from Bontrager's textbook of radiographic positioning. So in medical terminology, we have a number of different origins for the terms. Some are derived from Latin, possibly even Greek. Some are made up of word parts that also may be of a foreign language, but what we'll have is individual word parts connected with what we refer to as a combining vowel. And a combining vowel is usually an O. And then we have modern descriptive language in things such as nuclear medicine, and some of those things may be contracted into an acronym, like CT is CAT scan or computed tomography. CAT scan really means computed axial tomography, and that's kind of an archaic term, so it's really CT, or MRI, which is magnetic resonance imaging. So in terminology, what we have is a number of different things that you need to be aware of, body position being one of those things. So our body position is just that. It is what position is the patient in. So it may be the patient's body position may be upright, as in their entire body is upright. Fowlers means that they're seated but still upright, as opposed to semi-fowlers means that they're seated and partially upright. Lateral would be a position where maybe you're looking at a profile of the patient's anatomy. And then prone or supine just means that the patient's laying down, completely laying down, and there's some different orientations for prone position and supine position as well. So if they're laying on their stomach, that would imply that they are in a prone position, but it can also apply to individual anatomy. So your hand, if your hand is on an image receptor or x-ray film, so to speak, and the palm of your hand is down, then that would be what we refer to as a prone position, as opposed to the palm up would be a supine position, or if the patient is laying on their back looking up, then that would be a supine position as well. So sometimes we refer to body position as is described by its position according to the image receptor. IR means image receptor, and we'll talk about those here in just a bit. So some examples would be like a posterior position. We really don't refer to that all that often, but posterior position would be where the patient's back is up against the image receptor. Anterior position would be where the patient's front is up against the image receptor. Anterior means front, posterior means back. And then we have some a little bit of compound things like oblique. Oblique means that the patient isn't either facing towards the image receptor and they're not facing 90 degrees from the image receptor, which would be a lateral position. They are facing in some degree in between those two positions. So again, body position sometimes used to describe the position relative to the image receptor. We've got, it becomes more complicated with your oblique. So a posterior oblique would be where the patient is, their back is up against the image receptor and they're turned maybe at a 45-degree angle. That would be a posterior oblique, as opposed to if their anterior surface is up against the image receptor, that would be an anterior oblique. But it's not just enough to say posterior or anterior oblique, it has to be more descriptive. So the way I'm sitting with the chair behind me here, if the chair was an image receptor, the way I'm sitting is in a right posterior oblique. So my right hand side and my posterior side are closest to the image receptor, the back of the chair. So that would be a right posterior oblique, as opposed to if I'm turned in the opposite direction, again, we've got a posterior oblique, But in this case, it is a left posterior oblique. And the same would apply to anterior obliques. If my right anterior side was closest to the image receptor, then it will be a right anterior oblique as opposed to my left side. It's common to kind of conflate projection and position. And it's something you're probably going to struggle with for the first semester, or possibly the second semester, and then on tests after the second semester, you may get tripped up a little bit just because you're not paying that close of attention to the test question. So projection describes the path of the X-ray beam. So again, the front of the patient is the anterior surface, the back of the patient is the posterior surface. So if the X-ray beam is coming from in front of the patient and it strikes their anterior portion first and then exits their posterior portion, that would be an anterior-posterior projection. If we were going the opposite direction, the X-ray beam was behind the patient, the X-ray machine was behind the patient, and the X-ray was striking the posterior portion of the patient and then exiting the anterior portion, that would be a posterior-anterior projection. As opposed to a lateral projection would be where the patient is turned to the side. So really the lateral refers to both a position and a projection. Axial, though, is a little bit different. You can have axial in either AP or PA projection. AP means anterior or posterior. PA refers to posterior and anterior. So an axial projection implies that the X-ray beam has an angulation that goes with the long axis of with the patient's body. So an axial projection would be a projection where maybe the X-ray beam is coming from below the patient just a little bit, and it can be entering the anterior portion, exiting the posterior portion, and that would be an anterior-posterior axial projection. Axial just means that there's an angulation on the central ray, or the X-ray beam. Tangential sounds a lot like axial, but really with tangential what you get is a skimming of a body surface. So I've got a coffee cup right here. And in this coffee cup, you kind of assume that the coffee cup has a handle on it, but you can't really see it. The reason you can't see it is because the front of the coffee cup is in the way. And what we get with this is what we refer to as superimposition, which is a term that comes later in the presentation. But we get superimposition. That just means one thing stacked on top of another. So we have superimposition, the handle on the coffee cup. And from your perspective right here, you probably can't tell if this thing has a handle. It does. But what we can do is, if we oblique the patient's body, assuming this were to be a patient, if we oblique the patient's body, now we can skim the surface of the patient's body in order to visualize the anatomy that we want to see. So that is a definition of tangential, is a skimming of the surface. In pretty much all of these, the oblique positions, axial projections, and tangential projections, the purpose for those is to try to desuperimpose structures of interest. So the X-ray beam, we use certain descriptors for the X-ray beam. And whenever you start your clinical education, what you'll notice is a light field represents X-ray beam. But in the middle of that light field are what we refer to as crosshairs. The middle of those crosshairs are what we refer to as the central ray. The central ray is the middle dead square center of the X-ray beam. And in our positioning of the X-ray beam, we'll refer to the central ray and its entrance point in a lot of different cases. So we'll talk about that on each one of the individual exam types that we do. Collimation means beam restriction. So since we're dealing with radiation, we want to expose the patient to the least amount of radiation possible. So we want to utilize collimation. It's a little bit confusing. Whenever we're talking about collimation, if we increase collimation, that means we're going to apply more collimation, which gives us a smaller field size. So we want to use as small a field size as possible. We want to increase collimation as much as possible. And it's one of the primary ways that we limit the amount of radiation to the patient, the amount of radiation we expose the patient to. It comes with the understanding that if you over-collimate, if you increase collimation to the point that you don't include anatomy that you need to see, then you're going to have to repeat the exam and expose the patient a second time. So you want to collimate as much as possible while not over-collimating and clipping anatomy and not including that on the image. So that's central ray collimation. The source to image receptor distance, the source is an X-ray tube. So the distance between your source, that being an X-ray tube, and the image receptor, that's the medium that we use to record the image, is our source to image receptor distance. So if we were using a film, let's say, then our SID would be the distance from the X-ray tube to the film. But we use digital image capture now, so it's really from the X-ray tube to the image receptor. Object image receptor distance, or OID, is just that. It's the distance between the object of interest inside of the patient to the image receptor. X-rays behave a lot like light, so if you can learn a lot from just using a flashlight in a darkened room on what will happen as you turn anatomy or change your SID and your OID. But if you were to shine a light of just a light on your hand that's elevated off of your desk or off of your book or whatever, and you were to elevate that, increase your object to image receptor distance, what you're going to see is an increase in magnification. So SID, source to image receptor distance, that's from the X-ray tube to the image receptor, as opposed to OID is the distance from the anatomy to the image receptor. So what we want is an adequate SID, and we want as low of an OID as possible. Sometimes in our minds, position and projections sometimes become synonymous, and they are not. So watch your test questions, watch your answers, and make sure that you apply the proper answer to the question that's being asked. What I mean by that is maybe you have a test question that asks you what position would be described by the patient's hand, the palm of the hand being in contact with the image receptor. Some of your answers may say something to the effect of PA, or posterior anterior. That posterior anterior is a projection, not a position. So make sure that you understand in your test questions what it is that it's asking you. Sometimes it becomes difficult to differentiate between axial and tangential. Remember, your axial means that you've got an angulation with a long axis of the body, as opposed to the tangential is just skimming the surface. And tangential, we're going to have some very specific views of the tangential. And what I was describing with a coffee cup a little while ago, you've got a extension from your cheekbone that goes back to almost your ear. And that's what we refer to as the zygomatic arch. And sometimes a patient will break their zygomatic arch, and it's a depressed fracture. It's very difficult to visualize. So what we shoot is a tangential in order to see that. The kneecap is another, which is referred to as patella, is another view that we'll do a tangential on. And sometimes we'll incorporate an oblique with the tangential. So don't confuse those three. They're three separate things, oblique being a body position, but sometimes we'll use an oblique position to accomplish what we need to see in an axial, and especially a tangential. So decubitus, the medical term decubitus just means the patient's laying down. But in diagnostic radiography, we're going to use that body position with a particular purpose, so we'll describe that later on. So then you've got the compound descriptions that we talked about before, like AP projection, LPO position. So we have a couple of different types of X-ray images. Some are still radiographs, and some are moving radiographs. So when you do your shadowing in a hospital, you'll see both of those things. You should see both of those things if you're doing your shadowing in a hospital. A radiographic image is kind of like a freeze frame, kind of like what you would take on your phone. But if you took a video on your phone, that would be more analogous to fluoroscopic image. So it's moving x-rays. So you may have seen some movies in high school health class where it looked like a skeleton was eating a sandwich. That would be a fluoroscopic image. And we use that so that we can see mobility, see things move through the patient's body. So the x-ray image, we have some things as well that are a little bit confusing. Density and contrast are two of the things that we need to be able to visualize in order. Density refers to the amount of darkness an image displays, or at least a portion of the image. Whereas contrast is difference in those densities. The reason that we can see, let's say, bones is because they show up differently than what soft tissue or air shows up as on an x-ray. So those differences are what we refer to as contrast. They're different densities. Since we can see the difference in densities, then we have contrast. If our entire x-ray looked like a bone, then it would be very difficult to make any kind of diagnosis on that. So density and contrast, two of the major things that we need to see on an x-ray, and how we can control those things. The computer, for the most part, controls those. But if you're in your clinical rotation, or you're doing your shadowing, and you see the technologist adjust the contrast and density, the brightness level essentially, then what they're doing is what we refer to as windowing, and that will be window level and window width. Some more terminology. We have superimposition. I talked about that before. Superimposition is just the stacking of one thing on top of the other. Desuperimposition means that you can see things separate from each other, and sometimes we have to use oblique position in order to accomplish that. Sometimes that will be done with axial projection or something like that. Artifacts are things on an image that should not be there. So let's say you took a chest x-ray on a patient and they had a necklace on. That necklace needs to come off of the patient. Artifacts are anything that should not be on the x-ray. Some of the artifacts that we'll see are internal artifacts that you can't remove. Something like a pacemaker. Okay, I know I said that it should not be there, but on a healthy chest x-ray, the patient's not going to have a pacemaker. So that's that patient's normal presentation if they have a pacemaker, but it's still an artifact. In distortion, we have two different types of distortion. One is shape distortion, one is size distortion. I described what causes size distortion earlier, and that is if your OID, object to image receptor distance, is increased, then you're going to get a little bit of magnification. That's what you refer to as size distortion. Shape distortion would be more like, okay, so here's my phone. You can see the length of the phone. If I tilt it like this, you can't see the length of the phone very well. So that would be an example of shape distortion. So we want to minimize both of those things. We have different types of image receptors. Most of these are going to be things that you're not going to see in clinicals anymore. But the image receptor is the device that receives the X-ray beam and formulates the appearance of the image. So traditionally we used cassettes, these little hard plastic things with an X-ray film inside of it. We don't use that anymore. Photostimulable storage phosphor imaging plates are the first digital image capture, and we don't use those very much anymore. Solid state digital detectors is pretty much what we use now. They can be tethered to the image chain, or they can be standalone that send a signal to our computer system to formulate the image. So they can be portable. It's still solid state digital detector, and there are also fluoroscopic image receptors, some of those being digital as well. So what we see here, top left would be screens and films, top right would be an imaging plate, and then that bottom center would be a digital image receptor. So with a digital image receptor, again, that one looks like it does not come away from that unit, but a lot of them do. A lot of them can be removed so that you can make your image tabletop as opposed to using that large apparatus. So this whole thing here is what we refer to as a wall bucky. The bucky just refers to the apparatus that holds the image receptor, and we'll talk about that later on in a different class. So these are direct digital radiography types. Again, that one in the center we just took a look at. The one on the right, you see that wire, that's a tethered system that usually goes with a portable machine, as opposed to the one on the left is just a one that would send a signal to the computer system. So fluoroscopy, we have a couple of different orientations for fluoroscopy. Again, your fluoroscope gives you moving x-ray images so that we can see mobility of x-ray dye through the patient's body. And in the picture on top left, you're going to see two different things. So this is your image receptor. And in this case, what we have is the x-ray beam is down inside of the table, shooting up through the patient into the image receptor. That's an x-ray tube as well. You need to be real careful when you're in clinicals that if you have what we refer to as an RF room, that is radiography and fluoroscopy, that before you start moving this thing around, because it's very heavy, that you get this out of the way. This does not look like a good position for it. Being a two-dimensional image, I can't tell how far away that is. That might be the perfect place for it. But in a lot of cases, in a lot of x-ray rooms, this can get in the way of that. And if you tilt the table up, you can do some damage to that, or you can run the fluoro tower into it and do some damage to it as well. This is a different orientation where the x-ray tube is here and the image receptor is under the patient. So some of your fluoroscopes will reverse the projection. So if the patient's laying flat on their back on this thing, then your projection is actually posterior anterior, because the x-ray beam is coming from underneath the patient. Same patient position on this would reverse our projection to anterior posterior. So radiographic view is not really something that is used so much anymore, but that was used to describe a patient's body position in relationship to the image receptor. I still use view, but not in that same context. If I'm talking about AP versus PA, and it doesn't, in that portion of the lecture, it doesn't really matter if it's AP or PA, then I'll refer to an image of, let's say, the chest x-ray in those orientations as being a frontal view. So that has nothing really to do with anything in a textbook. That's just my personal use of the word view. Your projection or the appearance of the anatomy, for the most part, unless you have two images side by side, you really can't tell the difference between a PA projection and an AP projection. X-ray beam goes all the way through the patient. So if you shoot a PA chest, you're going to see the heart, you're going to see the lungs, you're going to see the ribs. If you shoot an AP projection, you're going to see all of the same stuff. It doesn't really change the appearance of the image all that much. So in that context, again, I'll refer to it as a frontal view. So that's just to explain what I'm talking about whenever I mention that. On all of your images, you have to have certain things. So what you have to have is something to identify the patient, and then something to identify the anatomy that you're looking at. So what we see then are the things that are required to make the image a legal document. So we have to be able to identify the patient, but we also have to identify the side of the patient that we're interested in seeing. So the required ID would be the date of the exam, the patient's name or ID number, and then that side, what we refer to as a side marker, that's that L or R that describes which side of the patient we're looking at. And then you also have to have some sort of identity of the institution where the exam was taking place. So in most of the hospitals, all the hospitals I think that I've ever worked in, they had both the patient's name and the ID number. So the more markers that you have, the more identifiers that you can have on the image receptor, the more specific it's going to be to that patient. So it's very common to have two patients with common names, like let's say John Smith. We have two John Smiths in the hospital at the same time. But if we have John Smith and we also have their date of birth, it makes things a little bit more specific. If we have John Smith, date of birth, and a specific ID number for each one, then it makes it harder and harder to make mistakes. So you may see more than that on the images that you create. So our placement is going to be based on the relationship to the long axis of the patient's body. So the image receptor, we can have the image receptor based in a couple of different orientations, either lengthwise or longitudinal, and that would be with the long axis of the image receptor going with the long axis of the patient's body. Horizontal or crosswise would be with the image receptor going across the patient's body. Or we can have corner to corner. So a lot of your digital image receptors now are square, so really horizontal crosswise or longitudinal lengthwise don't really apply all that much anymore. But some of your larger anatomy, like your forearms and things like that, you may have to still use that corner to corner orientation to get the entire anatomy on the image receptor. So when an image is created, what we have to look for are, is there superimposition? Is the superimposition proper? If we have obliquity, that where obliquity is not supposed to be, then it may take our superimposition, put it where it should not be. Can we see optical density? Is the brightness right? Is the contrast right? Is our spatial resolution adequate? Spatial resolution is lack of fuzziness. Is our shape distortion acceptable, or is there an absence of shape distortion, which is preferable? Can we differentiate between adjacent structures? So contrast resolution married to spatial resolution. And is there a presence of magnification? So contrast, we just kind of ran through that. Contrast, is it as black and white as it should be, or is it too black and white? Spatial resolution, does it look fuzzy? That is not fuzzy, that's supposed to be fuzzy. Does it look fuzzy in spatial resolution? So where we're looking for your contrast, this is too high contrast. The density is too low on the upper and lower portions of this, so that the difference in density is just too similar. As opposed to over here, you can see not only the difference between bone and soft tissue, but you can actually see the patella. That's the kneecap right there. That's what you're looking at there. And you can see separation of muscles. As opposed to over here, things start to blend a little bit too much. And you start to lose some of the anatomy on the lateral portions of the knee. So what we see is our density is too low, our contrast is too high, it's pretty close to optimum. Our density is too high, and again, our contrast is low. So spatial resolution is, again, the ability to visualize very small structures, and it's controlled by a lot of different things. Your image receptor being one of them, just kind of like the resolution on your digital phone. But also your geometric factors like your lines and planes. Are your distances right? Is your OID proper? Is your SID proper? Did you use the right focal spot? And we'll talk about that later on in different presentations. Was there presence of motion? Was the patient moving? So a lot of different things go into spatial resolution. So we also need to take a look at positioning accuracy. Is all the pertinent anatomy demonstrated? Like this is a forearm. We've really got too much demonstrated. We don't need to see the entire hand on a forearm. But did we collimate off the posterior portion of the elbow? We need to see the posterior portion of the elbow down to the proximal portion of the hand. So multiple images on an image receptor is really not a thing anymore with digital image capture. So just kind of scratch that. You got collimation, you've got rotation. Is there a rotation present? if there is rotation present, is the amount of rotation acceptable. Not every x-ray is going to be perfect. And then is your central ray location proper? So again, in this forearm, we want to be able to visualize from distal, the distal carpal bones, which are your wrist bones, all the way up to the proximal portion of the forearm, really the distal portion of the humerus. We also need to be able to visualize all that stuff that we talked about before, the patient's name or ID number, and we also need some sort of indication of what side we're looking at, just so that the radiologist doesn't read it improperly or make a diagnosis on the wrong arm. So most of the time we're going to get 2 x-rays of the same anatomy, and the purpose for that is because we're looking at a 2-dimensional representation of a 3-dimensional image. So if I were to put my fingers like so, in what you're seeing here, you're probably not going to see a whole lot of difference front to back, right? So if I rotate though around, then you can see that my fingers are not pointing directly towards each other, but rather they are pointing kind of off to the side from each other. So what we get in using 2 images at 90 degrees from each other, 2 projections 90 degrees from each other, is we get dimensional perspective. So again, looking at this image, this looks like the nail is going straight through the patient's knee, but if you look at the lateral view, or the lateral projection of this patient's knee, then what you'll see is that it missed everything except for the soft tissue. So sometimes we're going to have exceptions to the 2 views. All of the all the orthopedic surgeons that I've worked with have eventually wanted 2 views 90 degrees from each other. So this has not been my experience, but potentially in a post-reduction of a broken bone, then they may just want the 1 view. And what a post-reduction is after the doctor sets a bone, let's say we've got a broken bone and we've got a little bit of separation between them. So what the doctor does is they reset the bone and try to make the pieces line up, and then we take an x-ray, and that's what we refer to as post-reduction. But some of the anatomy that we shoot, we can't really get 2 views 90 degrees from each other and get any good valid information off of it, like pelvic bones. Our pelvic bones, for the most part, we're not going to be able to get 2 views. Our clavicles, we're not going to be able to get two views 90 degrees from each other. And in our abdomen, most of the time, we're not really looking for three-dimensional perspective. We're looking for gas patterns and things like that would indicate the patient maybe the patient has bowel obstruction. So when we're viewing radiographs, most of the time what we want to see is a radiograph as if the patient's looking at us in anatomical position. Anatomical position means the patient's upright, palms facing forward. That's anatomical position. So most of the time, that's how we're going to view x-rays. Not always, but most of the time. So we're going to be looking at the patient with their left side on our right side as if the patient's looking towards us. But there are some differences: lateral projections and decubitus projections, and some upper extremity exams as well. So our limbs, for the most part, are going to be anatomical position, except when we get to the hands and the feet. Most of your extremity views or extremity images, we're going to view with the big bone on top until we get to the hands and the feet. And then for the most part, we're going to view them small bone on top. So they don't follow anatomical position. So again, anatomical position looks like that. When we view, for the most part, those images in anatomical position, except for hands, wrists, feet, toes, as if the patient's looking at us. But sometimes for decubitus views, we're going to look at them a little bit different. So here we have a couple of different chest x-rays, and what we see here is the heart. The largest chamber of the heart's the left ventricle. The heart's really pretty much a midline, but the left ventricle is so large it appears that the heart is off to the patient's left-hand side. So this patient, we're viewing this as if the patient's looking at us, and their heart, their left-hand side, is on our right-hand side. Lateral, okay, so the textbook says the lateral chest x-ray is with the patient looking towards our right. I've worked with radiologists who like to have the lateral visualized looking to the patient's left. That's fine. That's a preference for the radiologist. Our decubitus images, so this bears a little bit of explanation. Decubitus means laying down. That's all it means. But in x-ray, what decubitus means is the patient's laying down and we're utilizing a horizontal central ray. So again, superimposition, if the patient's laying flat on their back and they've got fluid in the lungs, which is what you're looking at here, if they have fluid in the lungs, they're laying flat on their back with a vertical x-ray beam, then we're going to project the lungs over the top of that fluid, and we're not going to be able to tell how much fluid there is there. So what we do with a decubitus x-ray is we lay the patient on their side in most cases, and we utilize a horizontal central ray so that you can visualize the separation of the air in the lungs from the fluid outside of the lungs. So an x-ray decubitus is not just with the patient laying down, but it's the patient laying down with a horizontal central ray. So again, this is not comprehensive. This is just to get us into chest x-rays, which will be our next presentation or recording. If you found this helpful at all, please like, subscribe, comment. If you have any questions or if I need to clarify anything, please feel free to comment. Thank you for watching.